All right, let's dive into one of the most intense, high-stakes emergencies in all of neurology, status epilepticus. This is a condition where the clock is your enemy, and a fast, organized, protocol-driven response is absolutely everything. It's truly a race against time.
So picture it. Someone rolls into the ER, actively seizing. That clock you see, it's not a metaphor, it's real. With every single second that a seizure goes unchecked, neurons are being damaged. Our job is to be fast and to be right now.
So what exactly is status epilepticus? Well, the old definition used to be something like 30 minutes, but we've learned a lot since then. The modern definition is all about time. 5 minutes. That's our trigger to act. Why? Because we now know for a fact what the longer a seizure goes on, the harder it is to stop, and the higher the risk of permanent brain damage.
Now, here's something that can really trip people up. Not all status epilepticus looks like the dramatic convulsions you see on TV. Sure, convulsive SE is impossible to miss, but there's a much sneakier version called non-convulsive status epilepticus. The patient might just look confused, or maybe they're in a coma and not waking up after a seizure, but electronically, their brain is still seizing. And that's exactly why you have to get an EG on any patient with altered mental status who isn't getting back to their baseline.
Okay, so let's get into the management. We'll start with phase 1, the first 5 minutes. It's all about stabilizing the patient.
Think of this algorithm as your roadmap, your playbook for navigating the chaos. It's a clear, step-by-step process that we're going to walk through together. We'll start at the very beginning with that initial stabilization. In those first few moments, what do? We go back to the absolute basics: circulation, airway, breathing. Get some oxygen on them, get IV access, and get them hooked up to the monitors. And here's a huge one. Don't ever forget this. Check a fingerstick glucose immediately. Hypoglycemia is a super common cause of seizures, and guess what? It's also incredibly easy to fix. Correcting that blood sugar might stop the seizure right then and there. Okay, so you've done all that, the patient is stabilized, but they're still seizing. The clock is ticking past that 5-minute mark. It is time to deploy our first line of medication. And that first line of defense? It's all about the benzodiazepines. Your main options are IV lorazepam, IV diazepam, and IM midazolam. And honestly, they all work really well. The most important thing is speed. Just get one of them on board, fast. And if you don't have IV access yet, no problem. Intramuscular midazolam is an absolute lifesaver and works just as well as the IV options. So you've hit them with a benzo, maybe even a second dose, and they're still going. Now we're getting close to the 20-minute mark. It's time to escalate. It's time to call in the reinforcements. So who are these reinforcements? We have 3 main players for our second line of therapy: phospheniatoin, levetiracetam, and valproic acid. Big studies have shown that, for the most part, none is better than the others. The one you choose often comes down to the specific patient in front of you. But here's the non-negotiable part. You have to give a full, proper, weight-based loading dose. No skimping. Okay, now we are in the deep end. The seizure has blasted right through our first and second lines of defense. This is what we call refractory status epilepticus, and the stakes just got much, much higher. This is the scenario that keeps us up at night. You've done everything right, you've followed the protocol, but the patient is still seizing. What do? Well, this is where management shifts into a whole new gear, and we need to start thinking about the ICU.
And there it is. That's the official definition. The seizure continues even after a benzo and a second-line agent. Once you hit this point, we know that the mortality rate goes up significantly. This is a true fight to save the brain. So when do we pull the trigger and intubate? Well, a lot of the time it's because the drugs we need to use now are so powerful, they're going to knock out the patient's own drive to breathe. We also intubate to protect their airway or if they're just getting exhausted. Basically, we're taking over to safely use our most powerful tools. Once we're in the ICU, the game changes completely. We're now using continuous infusions of anesthetic agents like midazolam, propofol, or pentobarbital to put the brain into a therapeutic coma. The goal here is to completely silence all seizure activity, which we monitor with a continuous EEG. It's an aggressive move, but at this stage, it's what's necessary. Now, this is super important. While all this aggressive treatment is happening, there's another mission running in parallel. We've got to play detective and figure out why this is happening in the first place, because stopping the seizure is only half the battle. And our detective work starts immediately. We draw a whole battery of labs, looking for any metabolic issues. We get an emergent CT scan of the head to rule out things like a stroke or a bleed. If we're worried about an infection like meningitis, we consider a lumbar puncture.
all while that continuous EEG is running, giving us a live view of what's happening in the brain. So what are we hunting for? The list of potential causes is long. It could be anything from electrolyte problems to a stroke, to drug toxicity, or even a serious infection. But you know what the most common cause is for someone who already has a diagnosis of epilepsy? Simply not taking their prescribed anti-seizure medication. And that brings us to the single most important takeaway from all of this. If you remember nothing else, remember this quote. Success in managing status epilepticus isn't about having a secret magic bullet. It's about speed. It's about having a plan and executing it without hesitation. Because in this race against time, every minute you save is brain you save.